Hi, everyone. I'm happy to be here today and be able to talk about women's health. I feel like I've been a women's health advocate for quite a long. I've been in practice for about 30 years. And a bit of my backstory is I'm a graduate of the A.F. Williams Family Practice Residency here locally. Worked in Denver a few years and then moved to Montrose, Colorado to do full scope family practice. So obstetrics, ICU, geriatrics, etc., soup to nuts. And then I also went there and brought a bone densitometer as well. So my subspecialty has been osteoporosis and management of that. My solo practice does about 1,700 DEXAs every year in Montrose. So that has been my focus in addition to family practice. And then probably since 2016, I've focused on hormone replacement therapy, including pellets, and I've had advanced training in that. So you're kind of getting my perspective through my clinical experience, and then add on hormones. So hormone therapy was, in fact, in my training, it was the standard of care through the 80s and 90s. Premarin and Prempro were the #1 selling drugs for 2 straight decades. There were jokes that it was called vitamin P, actually, because it was so commonly used. A study done in 2001 of physicians showed that 70% of physicians felt that women should be offered hormones at the time of menopause. So unfortunately, that training now has gone away, as has been spoken about. So I don't have any disclosures. Very importantly today, I will be discussing treatments that are non-FDA approved. In family practice, you're doing at least 40% of things that are not FDA approved. For instance, treating a UTI. If you use nitrofurantoin or Bactrim, or a cephalosporin, none of those are FDA approved to treat UTIs. Gabapentin's not approved to treat back pain. So we do non-FDA approved things all the time. The FDA does not practice medicine. There's no textbook of FDA medicine, right? So, and quite honestly, if you're only using FDA approved treatments, you're not doing cutting edge medicine or up to date medicine. So, breast cancer. I feel like if I don't tackle breast cancer, like nobody hears anything I have to say. Everyone's brain's exploding that, well, you can't take hormones because it causes breast cancer. So it is, in fact, the most feared of women. When a phone survey done of women randomly called and said, what do you think you're going to die of? The majority of women said breast cancer. The reality is you're 7 times more likely to die of heart disease. In every single decade of your life, heart disease is more common than breast cancer. And in fact, more women die of lung cancer every year than breast cancer, actually. Yet we get continually bombarded with this message about this fear of breast cancer. Basically, we also are told the statistic of 1 in 8 women will die of breast cancer. That's also very misleading, because it's only if you actually live to age 85 that the cumulative risk is 1 in 8 die of breast cancer. So in fact, women at menopause, their risk of breast cancer is about 1 in 42. And as you get older, the risk increases from there. For I guess the majority, for women who have a family history of breast cancer, it doubles your risk. If you have the BRCA1 and 2 genetics, it increases it by about 10%. So interestingly, however, with those BRCA genes, 85% of women will get breast cancer. But then the question is, why don't 100% of women get breast cancer? Because it's a more complicated story than just that. So what happened? The WHI study is what happened. It essentially was the bomb that killed hormone therapy. So this was the largest NIH-funded study ever done. Ultimately, it cost $1 billion. It was initially started in the 1990s. At that time, there was a big push that we had no studies, no well-done studies on women's health. And in fact, the majority of how we practice medicine today is based on studies on men and then extrapolated to women. So the first and I believe only director of the female director of the NIH was Dr. Healy. So she pushed and initiated this WHI study to finally have a large randomized controlled trial to show the benefits of hormones. So this study was initiated with 40 years, basically, of very positive data on hormones and its cardioprotective effect. As this study got put together, however, a couple of things happened. The initial thought was since there's so much data on newly menopausal hormones being given to, newly menopausal women given hormones, that maybe we should look at older women and how they respond to hormone therapy. Additionally, it was felt that if you included women who had a lot of symptoms, that they would drop out of the study, because it would be so very obvious that if they got the placebo, they would have their hot flashes come back. So women with symptoms were purposely excluded from this study. Ultimately, 83% of the participants were more than 5 years past menopause. Additionally, the women who were selected were really a very high-risk group of women. 50% were either current or previous smokers, 80% were obese or overweight, a third had hypertension. So in a sense, it was almost a secondary prevention trial because those women were at such high risk. And then on top of this, the drug chosen was Prempro and Premarin. And in fairness, it was because that was the number one selling drug. So they thought, well, this is what we should study because this is what women are getting. Additionally, however, the primary researcher in this study was Dr. Rousseau. Dr. Rousseau is a cardiologist. I will tell you, no matter how much data you put forth on how good hormones are for cardiovascular risk reduction, cardiologists are not writing scripts for hormones. They will not do that, right? Maybe that's probably a good thing, but they are not. So Dr. Rousseau, who is the primary investigator for this study, as a cardiologist, was quoted about 4 years earlier in an article saying, all these women are on these hormones, are on this bandwagon, and that has to come to an end. So there was obviously some bias by the primary investigator about hormones in and of themselves. So after the data, there's a safety committee, of course, and so at a point in the study, the safety committee decided to stop the study because it was felt that there was an increased risk of breast cancer. A press conference was called. The researchers themselves were not notified of that until the last minute. They were given only, at 8 o'clock in the morning, they were advised of the findings, and they calculated the data and pointed out that it was problematic that the safety committee might have been off. However, when they brought that up, that information had already been released to JAMA, and JAMA was already in print at that point in time. So headlines came out stating that there's an increased risk of breast cancer with hormone replacement therapy. So that made media headlines across the planet. Millions of women stopped taking their hormones immediately because of that headline. And then what happened? The researchers themselves, I'm pretty sure that this translates into not statistically significant, but no headlines followed. And additionally, that initial headline was misleading. It should have said, at that time they thought it was statistically significant, that there was an increased risk in breast cancer in older women with a high cardiac risk who took Prempro. That should have been the headline. Not all women in this study had an increased risk of breast cancer, because the women who were newly menopausal on hormones actually did not have an increased risk. So, as pointed out already, the Premarin-only arm of that study had a lower risk of breast cancer. And if we were to believe that Prempro increased risk, it's 1 per 1,000, and essentially Premarin alone decreased it 1 per 1,000. So it would be a wash, but the Prempro arm actually wasn't even statistically significant. So that headline has yet to be rolled back or challenged in any meaningful way. We know at this point that negative headlines grab attention. And ultimately, the researchers of this study are a bit guilty, because they were like, it's $1 billion that was spent. You got to make some headlines. If you're spending $1 billion, you're not just going to come out and be like, oh, yeah, this just reaffirmed what we already knew. You had to grab headlines along the way. And that's what all those researchers ultimately did. And I will tell you another headline actually was in the New York Times that came out about 3 years after the breast cancer headline was, our data didn't show that it improved any quality of life or treated any symptoms. Well, as I've already mentioned to you, they recruited women who had no symptoms. So, oh snap, we didn't show any improvement in symptoms in women who didn't have symptoms, right? That was on the cover, that was front page New York Times. Hormones don't improve symptoms of menopause, which is nonsense. If you take care of women, hormones treat symptoms. But that was another negative media grab on the part of those researchers. So, Peter Attia, some of you might recognize that name. He's a pretty popular podcaster. He's a Stanford grad, professor, I think, a neurobio researcher, sort of anti-aging doc. And, he recently jumped onto hormones and kind of promoting them about 4 years ago. And this is his take on the study itself. And in general, it's essentially was unethical that what the researchers went out of their way to do is distort the actual data and promote this negative image of hormones themselves. Ultimately, the WHI 13-year follow-up data, Premarin alone, lowered risk of invasive breast cancer and lowered risk of fracture. So the 82-year-old patient who was mentioned earlier who got breast cancer, guess what? That oral estrogen that she was on actually lowered her risk of getting breast cancer. And in fact, because she was on estrogen at the time of the diagnosis, she has a 40% better chance of surviving that breast cancer. So you should high five her for being on the estrogen, actually. And then the 15-year data, all of that, those headlines like cardiovascular disease, et cetera, those have been quietly rolled back by the researchers themselves, retracted in journals, but there are no headlines to go along with that, unfortunately. So what's happened after the WHI study? Well, not surprising, hip fractures have gone up. And there's probably a multifactorial effect why that has occurred. DEXA reimbursement has gone down. This sort of negative, like, oh, you can only use bisphosphonates for 5 years. Less than 20% of people who get a hip fracture get osteoporosis addressed. I mean, that's a horrible statistic. Imagine folks who had a stroke who didn't get blood pressure checked, right? Or blood pressure addressed after you had a stroke. So imagine you have a hip fracture and nobody talks to you about your bone health. So the WHI study did in fact show a hip fracture risk reduction for women who took hormones. I will say the serums that are out there, there's no data that they reduce risk of hip fractures. Um, and the trend and increase rate of fractures continues to rise. I think due a large part because of the fear of hormones. And here's this one of the saddest stats. So we're all aware of increased suicide rates in adolescent girls, and we attribute that to social media most likely. However, the highest rate of increase in suicide is women between 45 and 54. The highest increase is in that age range. So that that has got to be addressed. And can I make a case that hormones are contributing to this? Absolutely. There's an inordinate fear of hormones that is not justified based on 60 years of data. And because it has fallen away from training, basically, like people show up at their provider's office, and those providers don't know what to do with those patients. A survey done of OB/GYN graduating residents showed 2/3 of them felt uncomfortable managing menopause. And then a different study of the 25% of residents more recently who've gotten training, they've had only a couple of hours of training, or even worse, they just get WHI training and told, very superficially, like hormones are bad, is what they're told, which again is not the accurate message that people should be getting. So women are suffering, they're losing their jobs, they're losing marriages, their minds, etc. And it doesn't have to be this way. US Preventative Task Force Services, like we hear about their guidelines. And I'm utterly in disbelief that I could be at this 30 years basically. And it was only in the last year that I learned that this is not a government agency. Like like this to me it's a little bit mind-boggling. So they're an independent organization. I mean, they get to present to Congress once a year, but that's it. There are 16 independent people that you could apply to be on this task force. So, in general, the people who are on this task force have a focus in public health or social equity and access to care. They are not necessarily specialists, yet they're putting out guidelines. Well, I should say they are specialists, but not necessarily in the guidelines that they're putting forward, right? Who knew? So, oh, wait, let me go back. So they put, oh, I'm sorry, my slides. Nope. Well, so their guidelines on hormones were basically that hormones should not be used for the prevention of chronic disease. Um, okay, who does that anyway? Who does that? Do I have a 75-year-old in my office who's an obese smoker and I go, "Hey, why don't I put you on some hormones to lower your risk of chronic disease?" Right? That never happens. We're barely treating women with horrible symptoms. We're not offering hormones to prevent chronic disease. But what did this grab for the task force? A headline. They got a headline, hormones are bad, and they got their media attention that they were after. However, when you read the fine print of that recommendation, um, it didn't apply to any women who had symptoms, right? But the headline didn't imply that. The headline implied hormones are bad. So, if you have anyone sitting in front of you that has symptoms, the WHI study doesn't apply, nor does the US Preventative Task Force guidelines. That also doesn't apply, but you have to read the fine print to get through to that. So, this statement, this sneaky little negative statement, is not based on any data. In fact, the data would imply the longer you're on hormone therapy, the greater the risk reduction you actually have. So this, again, negative imaging, this would be to me, this is like me saying, well, if you're gonna smoke cigarettes, just smoke a few, right? So this needs to go away, and unfortunately, this is still the message you're getting from NAMS and ACOG, despite data supporting the opposite of this. The devil in the detail, however, is synthetic progestins. So not progesterone, synthetic progesterones. They've basically been shown to increase women's risk of breast cancer by about twofold. If you want to sort of ferret out the differences among the synthetic progestins, medroxyprogesterone, which is a WHI progestin, increases risk by about 1.7. And so that has gone away. It's not really used. And unfortunately, a lot of providers have gone to norethindrone to replace that, and that actually doubles women's risk of breast cancer. So if ACOG and NAMS are not going to distinguish between the differences in progestins, then you're going to wind up with some statement like this. And the politics and economics of this is there are drug companies behind production of these synthetic progestins. So they're not going to necessarily come out and single out a single drug company. And that's just unfortunate that they're not willing to do that. And additionally, this statement, I've already discussed bones and bones fracture and the economic impact that potentially has. If you take hormones and then you choose to stop, your bones suffer. And within 6 years of stopping that hormone therapy, your bones are like as if you never took them at all. So this statement also would be detrimental to preventing hip fractures. And I might add that the same number of women die of breast cancer as hip fractures on an annual basis. So how do we evaluate the data? It gets very complex. And the further along I got in my sort of expert education in hormones, you realize how challenging it gets to ferret through this data. So what type of hormone was used? Was it synthetic? Was it bioidentical, meaning estradiol, micronized progesterone? How do they deliver it? There's obviously differences in whether you put on transdermal versus a patch versus a pellet versus oral, and that actually can have big treatment implications, because, for instance, if you're giving anybody estrogen in any way, shape, or form, other than, I suppose, a low-dose vaginal preparation, but if you're giving estrogen, the only data out there that reduces uterine cancer risk to oppose that is oral progesterone. You cannot use topical progesterone cream to protect a uterus. And in fact, probably the dose of micronized progesterone you need to protect a woman's uterus is 200 milligrams. So the current combo product that's out there is only 100 milligrams of progesterone and 1 milligram of estradiol. And in my opinion, that's not an adequate dose to protect the uterus from uterine cancer. And then timing. When did you start it? Did you start it within 5 years, 10 years of menopause, or did you start it after that? And when we look at increased risk of clotting in older women, as the WHI implies, again, it's Prempro. So micronized progesterone does not increase risk, but synthetic progestins do. And actually, if you ferret out differences between oral Premarin and oral estradiol, it's actually only oral Premarin that increases risk of clotting. And again, even that was a little bit overblown in the WHI study. If with the cardiovascular purported risk, that's again with synthetics and not bioidenticals, and again, overblown data. So if there's, in theory, 10, I'm sorry, 30 purported clotting events per 10,000, yes, that's an increase, but 30 per 10,000 is not much. And we do other things that have far more risk that we don't even really talk to patients about. And I will point out that statins increase risk of breast cancer. There's at least half a dozen studies showing anywhere from a roughly 17 per 10,000 increased risk of breast cancer to a 75 per 10,000 increased risk of breast cancer with statins. So who's handing out a statin to patient and saying, oh, by the way, this increases your risk of breast cancer more than the WHI study? Nobody. But again, it's a little bit of this fear mongering to women and people making decisions for women. And then, did you even look at the right hormone to begin with in your study? Testosterone is in this mix. I've, the rumblings of the pellets and testosterone pellets and what to do, but menopause is a lack of testosterone as well. And many of these large trials, they didn't even consider the impact that testosterone might have on any of these effects. So if nothing else, it's important to go, the WHI study is not a class effect. Like, you don't have one, like there's been statins taken off the market because of their ill effects. Yet we didn't throw all the statins away because there was one bad statin, but somehow this is what we did with hormones. So the Dayton study, this is a landmark study done by Dr. Rebecca Gleiser out of Dayton, Ohio. She basically is a breast cancer surgeon who has essentially just gone to using testosterone pellet therapy to lower women's risk of breast cancer and actually treat women with active breast cancer with testosterone pellet therapy. She combines those pellets with a aromatase inhibitor, typically anastrozole, and she has some pretty impressive results to show. She has basically, most recently, she's about to release, I believe, her 15-year data, but her initial study at 5 years showed a 50% reduction in breast cancer giving women testosterone pellet therapy. So these are women without breast cancer. And what she was after in that study to show was that you can treat women's menopausal symptoms simply with testosterone without using any estrogen or progesterone at all. And basically with testosterone pellets, she showed that 95% of symptoms improve with only giving testosterone. And as far as her breast cancer risk reduction, there was a 50% reduced risk at 5 years and a 75% reduction at 8 years with testosterone alone. To give you an index, tamoxifen lowers risk of breast cancer by 29%. Tamoxifen also increases your menopausal symptoms, increases uterine cancer risk and blood clots, and causes bone loss. So testosterone alone was actually more effective than tamoxifen for reducing women's risk of breast cancer. And interestingly, it was in fact testosterone that was the standard of care to treat metastatic breast cancer up through the 1990s until tamoxifen came on the market. So testosterone is an important piece of women's health that has been neglected and ignored. So these three mammals, what do they have in common? They're the only mammals that go through menopause. That's a pilot whale, if that threw you off. So we are, in fact, the outliers who go through menopause. Do we have any idea why that is? Has anyone bothered studying that? Not really. Every other mammal, like chimpanzees, elephants, they're having babies into their 60s, actually, or longer. Yet here we are. So if you ever see one of those menstrual cycle graphs, it's rare that they put testosterone on there. If they do put testosterone on that menstrual graph, it usually is some little tiny line at the bottom with a blip mid-cycle, right? Um, well, what they don't do on those graphs is label the units of measure. So if you equalize the units of measure between testosterone and estrogen, this is actually what the graph should look like through a woman's life cycle. Testosterone is reported in nanograms per deciliter. Estrogen is reported in picograms per milliliter. So women actually have 10 to 20 times more testosterone than estrogen. It's erroneous to think that testosterone is for men and estrogen is for women. That's 100% not true. Men have estrogen, women have testosterone. And in fact, you could argue that testosterone is our dominant sex steroid. 80% of what our ovary produces is, in fact, testosterone. A small percentage of that testosterone is converted into estrogen. So without testosterone, there isn't estrogen. And I will preface that there is some estrogen made in fat, but it's usually estrone. So as you can see, the effects of oral estrogen, so you know, at menopause, as you see, testosterone levels are declining. They've been declining since mid-20s. If you put a woman on a birth control pill, that lowers bioavailable testosterone. And if you put a woman on oral estrogen, it lowers bioavailable testosterone because you're increasing sex hormone binding globulin. That's the effect. You're sopping up the free testosterone. So this is an important thing to keep in mind. You know, these could be tackled if you also gave back testosterone to counterbalance that. Perimenopause. So I like to refer to this for many women, it's the decade of PMS from hell, right? This is for women, they show up, they're tired, they can't sleep, they have night sweats, they have dysphoric mood, and what do they get? SSRIs. So women in their 40s are prescribed twice the rate of SSRIs as the general population. While they sometimes just get a pat on the head. I mean, for the women showing up in my office with these complaints, what else do I ask them? Well, how's your libido? And their answer is, well, what libido? Right? They're not there actually because they have low libido. They're there because they have all these symptoms. They need a nap at the end of the day, etc. So, why is that? So when a woman reaches 40, she has only about 50% of the testosterone that she had in her 20s. If at any point you are thinking about, well, I should check her thyroid, testosterone actually needs to be on the list as well. Their symptom deficiency syndromes overlap quite a bit. We, as a concept, fix thyroid all the time. Well, your thyroid's low, let's fix it. So why aren't we considering testosterone being low and fixing that as well? At the moment, there's actually no ICD-10 code for androgen insufficiency in women. There is a code that I got injured because I was hit by a macaw, but not androgen insufficiency in women. So testosterone is vital for living and loving over age 40. Yes, in fact, it's a sexual hormone. However, if you only think of testosterone in that way, you're missing the boat on testosterone. So those SSRIs that women are handed as well in their 40s, while it may fix a few symptoms, it lowers testosterone by about 50%. So that explains why women on SSRIs, 70% of them report low libido, and about 20% report anorgasmia on SSRIs because it lowers bioavailable testosterone. So there's a lot of things that lower testosterone. Lifestyle issues, of course, and big ticket items as listed there. So erectile dysfunction does not equal low libido in women. I have about 30 things to offer men that have erectile dysfunction. I don't have anything meaningful that I can offer women, sadly. The FDA did, in fact, approve a drug called Addy. Congress pressured them to approve this drug. It's promoted for low libido in women. Great. You have to take that drug every day. You can't have any alcohol with it. It has a black box warning that you may faint or have hypotension, and it increased the number of sexual encounters one time every 2 months, and it's $800 a month. I'm pretty sure $1,600 going out to dinner away for the weekend would have done better than one more sexual encounter, right? Better spent money elsewhere. There's always this in search of the female Viagra. Erectile dysfunction is you would like to have sex, but your penis doesn't function adequately, as opposed to, nah, I don't feel like having sex. Those are two different issues. And I'm waiting for the day when I have like a men's support group for their ED. This is what we do for women with menopausal symptoms. Wear layered clothing, go to yoga, get a massage. I'm waiting for the day when men are going to be told that for their ED, right? Just not happening. So sexuality begins at birth and ends at death. We have a lifelong need for caring and companionship. Actually, loneliness is a bigger predictor of heart disease than smoking. There's over 1,000 studies looking at testosterone and sexuality in women. So when I hear people saying, well, there's just not enough data, I'm like, that's nonsense. There's not enough data. Testosterone for men and women alike is the driver of desire, sexuality, pleasure, fantasy, and orgasmic quality. Men have it clearly addressed more than women. So 25% of couples have no sex marriages. That means that they're having sex less than 10 times per year. That's unintended celibacy. And that's often related just simply to low testosterone. I see many women in my practice who they're seeing me for their bone improvement using hormones. And then they come in like, I'm like, how you doing? Like, good, I'm having sex again. I'm like, okay, when was the last time you did? 4 years ago, right? So of course you have to screen for sexual violence, domestic abuse, etc. But if your testosterone's low, your libido is going to be low, among other things. So they've shown that couples who are in fact sexually active have a 40% lower divorce rate. They also report more happiness both inside the bedroom and outside the bedroom as well. The benefits of intimacy are similar to the benefits of exercise. So, Dr. Greenblatt, Journal of Obstetrics and Gynecology, 1949. First testosterone pellets went in women in 1939, actually. First treatment for menopause was a drug called Ovarian that was basically cow ovaries that were dried, pulverized, and given to women. That was approved, I think, at 1899. So the life expectancy at that point was about 50. So if you were old enough to get to if you were lucky enough to get to menopause, and you were a woman of privilege, you could get this desiccated cow ovary to treat your menopausal symptoms. So the assumption, of course, was, well, it's a cow ovary, it must be estrogen. Well, In fact, when it was analyzed, 80% of that ovary is testosterone, and only a small part is estrogen. So, in fact, we've been treating menopausal symptoms with testosterone for well over 100 years, unbeknownst to us, because no one actually really looked until recently what's in that cow ovary. So, Dr. Greenblatt put out this study, published in 1949, and it's testosterone pellets that's on the left side there. And the indications for use of T pellets was for basically women who didn't respond to just estrogen alone, treatment of endometriosis and fibroids. Like, how come that's not on the menu at this point for treating these disorders in women when we've known since data from the 1940s that you can use testosterone for that, treatment of metastatic breast cancer. And my favorite is for women who are not psychologically frigid, who would like more libido, to use testosterone. That's a pretty big statement in the 1940s if we think about where women were at that point and their, sexuality, etc. So we've known about testosterone a long time. However, 2004, there was a testosterone patch up for FDA approval. FDA was a little, I think, shell-shocked after the WHI study. There's also amazing bias by the medical community against female sexuality. The T patch was up for approval for women who had a total hysterectomy. So lots of great data showing it worked. However, the acknowledgement that women's sexuality was important was obviously not the case for what the FDA felt it to be. So the FDA chose not to approve the patch despite great data. It did go on to get approved in Europe and in Australia. And I think the ownership that testosterone is the pleasure hormone for men and women, and our puritanical sex-obsessed society still can't acknowledge that sex, in fact, is for pleasure. For every 1,000 sexual acts, there's one child produced. Sex is for pleasure. Yet what do we learn? If you learn any sexuality education at all in high school, it's how not to get pregnant sexuality education, and doesn't even begin to discuss the importance of sexuality, intimacy, and pleasure in and of itself. So, vulvovaginal atrophy. 85% of menopausal women will get incontinence. Some of them so severe they become homebound over it. And pain with intercourse. Who wants to have sex if it's painful, right? Nobody. And frequent UTIs. How many older women, especially nursing home women, they're on that constant into the ER again because they have urosepsis, right? That is so unnecessary. It's so simple to fix, and yet we don't, because of an unfounded fear of hormones. Vaginas do not need lasers, right? I haven't met a vagina I can't fix with hormones. We don't need laser vaginal rejuvenation therapy at medical spas. These are unnecessary, right? We have hormones to treat this, and there's years and years of data supporting this. ACOG. This is a position statement from ACOG from 2016. So this statement is for women who have a history of breast cancer. They have breast cancer. There is not one single study showing harm from vaginal hormones. Not one. Yet we're still led to believe that it's dangerous and you shouldn't treat it. So here's the ACOG statement even endorsing that as well. This is what I use for from a compounding pharmacy to treat vaginal dryness, pain with intercourse. All three of these hormones have been shown to be beneficial for vulvovaginal health. The androgens, DHEA and testosterone, basically, if you look into urology data, the annual Urologic Association meeting in 2017, they spent a large part of that conference showing the importance of DHEA and testosterone in vulvovaginal health. And additionally, when you look at women who have primary ovarian failure, this is clear evidence that those women need to be treated with hormones. But interestingly, in those studies, when they only gave vaginal estrogen, while it improved some symptoms of vaginal dryness, it didn't improve all of them. And in those studies, it was because they only gave vaginal estrogen back and didn't put DHEA or testosterone. So if you said to me, well, I don't use compounders. Well, sure, if you would like to write for the newly FDA approved Introsa, essentially it's DHEA. But that's going to run you $280 a month. So, we're all hoping that the FDA approves something, but at this point in time, when they do approve something, it's unaffordable. It's unaffordable for women. So compounding pharmacies also get a bit of a bad rap. You hear from NAMs and ACOGs, they across the board say you shouldn't use compounding pharmacies. Potentially there's not quality control. Potentially there's not the right amount in there. We'll tell you what. Study done looking at our pharmaceutically made products, looking at data from 2013 to 2018, so 5 years, there were 8,000 recalled drugs. 8,000. 80% of our pharmaceutically produced products are made in India and China. And in fact, 2,500 of those factories have gone uninspected in 5 years. 1,600 of them have been uninspected in more than 10. Go visit your compounding pharmacy. Usually, they're very professionally run, and they have quality control. So, according to ACOG and NAMS not supporting compounding pharmacies, what are women supposed to do? Just continue to sit and suffer? We have 80 years of data looking at testosterone in women, and then how are you supposed to treat these women? Just because it's not an FDA-approved product doesn't mean you shouldn't treat them. And in general, just having the knowledge, you can potentially send them somewhere to get treated if you're not comfortable treating them yourself. So testosterone in women and in men. So adrenal steroids. So your adrenal glands make about 10 to 15% of testosterone production in men and women alike. And then gonads are what produces testosterone predominantly in men and women. So women obviously have far less testosterone than men. Many of its functions are overlapping, but there's some slightly different effects. If you look at the top of this, it's cholesterol. Cholesterol is the building block for these sex steroids and for cortisol. So I would have you pause when we're so focused on lowering cholesterol in this society. You can't live without cholesterol. Cholesterol, in fact, is what creates cell membranes. It's what gives the cell membrane its fluidity. You need cholesterol actually to make vitamin D as well. And the also on this graph, you'll see that estradiol is actually made from testosterone as well. Heart disease. We've reviewed heart disease a bit as well. The data looking at primary prevention for heart disease using hormone therapy is pretty profound. The Nurses' Health Study, 120,000 predominantly Caucasian females, 40 years of data, shows about a 50% reduction in heart disease for women who take hormones. Ideally, you're starting hormones at the time of menopause. That's when you have healthy endothelium. There's actually data showing that both testosterone and estrogen maintain the endothelial lining. So you would prefer to start with healthy endothelial lining and then maintain that. There's evidence showing that if you do start within 10 years of menopause, there's about 30 randomized controlled trials showing a reduction in coronary artery calcium scores. So that's a reduction, not a slowing of progression, actually reduction of coronary calcium scores. A reduction of cardiovascular events by 50%, a reduction in overall mortality by 35%. Okay, there is not data that statins lower mortality for women. And with hormones, cardiovascular disease mortality was reduced by 66%. There is no single drug that has that kind of data showing risk reduction. And in fact, there was an offshoot of the WHI study by a study published by Dr. Mason in 2007. She was one of the main researchers. She's out of Brigham and Women's. They had followed coronary artery calcium scores for women on the Premarin-only arm. They had over 7 years of data, over 1,000 women, and showed with Premarin, there was a reduction in coronary artery calcium reduction. That should have been a headline. That should have been shouted off the rooftops, yet it wasn't. And it's unfortunate. And it is also very clear that women with primary ovarian failure or early menopause, the data is also clear that those women need to be offered hormones. ACOG endorses that they should be given hormones. And that if they're not given hormones, they have clear increased risk for heart disease, stroke, osteoporosis, and dementia. So of those women, you put them on it. And then what's a mystery to me, they say, well, put them on them till 50 and then stop. Well, that's the implication. Well, because then they would have been menopausal. I'm like, so then they should get all those crummy risks. But somehow that's the disconnect. So there's not a reason to stop hormones. And essentially, there's improvement in risk reduction when you continue them. Secondary prevention data. We often will look at the HERS trial. So when I was a resident, which was pre-WHI, there was such compelling positive data on hormones that as a resident taking care of patients, women with their first heart attack, they left with a script for Prempro or Premarin, right? Because the data was that clear on how beneficial hormones are for women. So they actually did two trials, the HERS trial, where they looked at that. And unfortunately, there was an increased risk of events in the first year when you gave women either of those treatments. However, if you made it past the first year, as we've already established, the risk of clotting is in the first 9 to 12 months. So the HERS trial basically showed that if you got yourself through the first year and you didn't have an event, by year 3 and 4, you had a 40% reduction in cardiovascular risk. 40%. That's a big number. So in thinking about hormones for primary prevention of chronic disease processes for women who are menopausal with symptoms sitting in front of you, yeah, absolutely. But choose wisely among what you choose to start them on. Importantly, observation does not prove causation. And there's so many headline grabs with observational data. And our brains get a little bit tricky sometimes because we want to connect those dots. So for instance, if I put data and say, well, there's an association between the number of TVs you have in your house and obesity, you would go, yeah, I can see that. Sure, your brain goes, yeah, you're watching TV, you're snacking, you're getting ads for pizza, you're not moving, you watch TV. Sure, I could see, that obesity and the number of TVs in my house are associated, right? Because but however, are the TVs actually causing obesity? If I'm a TV hoarder and I have 50 TVs in my basement, am I more likely to be obese? I'm not, because TVs don't cause obesity. But this is what our brains do. So you have to be very careful with observational data that you don't automatically connect the dots. Because many times in these studies, the hormone is the innocent bystander when they're measuring hormone levels at a time of diagnosis of whatever disorder, right? What you're looking at is, if I give someone treatment, what outcome difference did they have? So, if you learn nothing else from this presentation, it's be critical of observational data. It can be helpful, but you need to be critical. As you've already learned from me, not all hormones are created equally. Obviously, synthetic versus bioidentical versus bioavailable. So there is a concept and a back and forth, like bioidentical is safer. The disconnect is that you can write scripts for bioidenticals that you get from a regular pharmacy. You're giving estradiol, that's in fact bioidentical. You're giving micronized progesterone, that is bioidentical. Versus, is it bioavailable? So for testosterone, for instance, if I gave testosterone orally, you digest it. You don't absorb it. So you have to give it in a different way so that it is, in fact, bioavailable. So the bioidenticals, estradiol and progesterone, the reality is all of those, I mean, they're being made in China. They make those, like, micronized progesterone, all that's coming from China. It gets to, some of it goes to the pharmaceutical industry and they make a capsule. Some of it goes to the compounding pharmacy, and then they create it into different products. So as I've already mentioned, like, very little is actually made within our borders. So our FDA, people go like, well, it's not FDA approved. And I'm like, you mean the FDA that approved OxyContin in 11 months and fast-tracked OxyContin, that FDA? The FDA that approved Addyi, as I've already mentioned, as worthwhile for low libido in women. The FDA that approved aducanumab, so the Alzheimer's drug, the plaque puller. That was fast-tracked. The FDA is currently, just recently, being investigated for approval of that drug because not one person on the expert panel actually recommended it be approved, yet it got approved. Right? When you're gonna charge $56,000 a year for something, it got approved. Right? There's a lot of money at stake. So, while that medicine is pulling plaque, they haven't shown an outcome benefit. There are, in fact, studies showing that both estradiol and testosterone lower amyloid and remove amyloid plaque of dementia. But the most important piece of that equation is that there's a neuron that's alive under that plaque. Ideally, we're looking at preventing dementia. We worry about breast cancer. If you get breast cancer, there's a 90% cure rate. If you get Alzheimer's, there's a 0% cure rate. So prevention, depending on what data you would like me to quote, there's anywhere from a 20 to 70% reduction in dementia with using hormones. Our brains run on estradiol. There's very clear studies looking at women's brains before and after menopause. So menopause is when estrogen falls off the cliff. The PET scans are jaw-dropping when you look at brain function before and after menopause. And in fact, estrogen is so important for brain function that in men, the enzyme aromatase that converts testosterone to estrogen, the highest concentration of that enzyme in men is in their brains. because, like us, their brains run on estrogen as well. And in fact, women are 2/3 more likely to get Alzheimer's than men. You have to say, well, why is that? Well, a 70-year-old male has more estrogen than a 70-year-old female. So, after age 60, twice as many women are diagnosed with dementia and Alzheimer's compared to breast cancer. So, if women fear anything more than breast cancer, they fear dementia and Alzheimer's. So I think the message that needs to get out there is let's start preventing Alzheimer's and dementia. And the only thing to do that is hormones. So that needs to be the new message, I think, as instead of this fear mongering that we go through. This is what I felt was useful to have at the end of this presentation. These are the forms that are available. Distinguishing data between Premarin and estradiol is important. Even though there's great risk reduction with Premarin, it does increase risk of clotting, a small amount. Oral estradiol actually does not. So when you plow through those studies and dissect them, it's actually oral Premarin that increases risk, not estradiol. Transdermal estrogen does not increase risk. Micronized progesterone doesn't increase risk of clotting. And then if you sort through the data, as I've mentioned, the WHI oral estrogen studies, and in other studies, it's oral estrogen that lowers risk of cardiovascular disease because you want it going through the liver. That's in fact how it improves lipids. And there's about 7 different markers of inflammation that go down with estradiol. It's oral Premarin that increases CRP. However, despite even increasing CRP, clinical outcomes show that you have risk reduction with Premarin. So again, you need to be careful of, we can look at all these markers, but at the end of the day, how did it impact outcome? Testosterone here, as you see, those pellets, small, they are compounded in 503B FDA-approved labs that I actually are inspected. Imagine that, because they're here in the United States. And you could give it topically via cream, sublingually via a tablet that goes under your tongue, or via a pellet that typically lasts 3 to 4 months in women, 5 or 6 months in men. So in my clinical practice, adding testosterone has been a game changer. It's sort of the missing link, in my opinion, in my clinical practice for women. And it often can treat many of the symptoms and the data, as I've already shown you. But in my opinion, you need hormone balance. So all 3 of these hormones need to go back, and they need to all be balanced out. And even in women who've had a hysterectomy, they still need progesterone. It's pretty narrow to think that the only role of progesterone is in our uterus. I mean, there's very clear evidence that micronized progesterone, either it's neutral or it lowers women's risk of breast cancer. It has neuroprotective effects. It is great to help women sleep. I half jokingly call it Mother Nature's Valium. If women have trouble initiating sleep, you give it an hour before. The metabolites of progesterone affect GABA receptors in your brain. That's kind of the volume control. So progesterone works well. I use it also even for women who are like, well, I don't want to take any hormones, but they need to sleep. There's very clear evidence that you have higher rates of dementia if you don't sleep. So for whether you have a uterus or not, progesterone is beneficial. And as a concept, though, I think all of these need to be balanced. But if you have a woman who's like, I am not taking estrogen, just give her progesterone, and that's okay too. And that'll actually treat many of the symptoms that she has, even with progesterone. There's data to support that as well, in addition to the testosterone, as I've mentioned. So I think it's time that we get training going again in residencies and in medical school. I think Our patients trust us, and I think they deserve a place to come to get accurate, evidence-based medical information. We need to be a resource for that. And family practice needs to be back at the wheel, taking care of women and managing perimenopause and menopause so that, they don't need to go to medical spas and clinics and companies. They need to be able to come to their primary care physician and get the treatment that they deserve. So thanks for this chance to come and present this. Questions?
Thank you both for great presentations and all the information. It seems like it could be real practice changing for a lot of us. Since we can talk about off-label uses, what about using other testosterone preparations in women? We have patches and injections that we have a lot more experience with in men. I mean, can you use a androgel in a really reduced dose or a different dose and make it effective? How about using the testosterone cypionate, other options like that? And could you tell us more about pellets?
Sure. So yes, that's what many providers will do. They'll just order androgel, and you can either get androgel in like a tube, like kind of a toothpaste tube, or little packets. So you don't want the packets because you're going to use so little. So you could get the tube, and it's a 1% gel. So that's roughly 10 milligrams. So you can use a tiny bit of that gel and have women apply it to areas that don't grow hair, because it acts as like fertilizer to hair follicles. So you could put it sort of the inside of your arm, behind your knee, inner thighs, and you can often just try one dose at bedtime. And the middle of the night sweats, I'm a furnace, is often low testosterone. Progesterone helps that as well. The daytime hot flash is low estrogen. But the sweats and it's 2 a.m., I can't get my brain turned off, is often testosterone. So that's why the bedtime dose, but you could certainly use it in that way versus compounded testosterone cream. For men, in my opinion, the androgel, there's not enough testosterone in androgel to effectively treat men and get the levels you need. It's also recommended at once daily dosing, when really you need twice dosing in men, actually. And sublingually, I use that sometimes for women, a tab that goes under their tongue, and I would use that twice a day. Testosterone pellets typically last 3 to 4 months from women, and those, there's a whole range of doses that you could use for pellet therapy. The vast majority of people I take care of, but women I take care of, use pellets. Testosterone, I would say the majority probably use injectable testosterone cypionate, used weekly. There is a preparation, testosterone unguenate injectable, that lasts almost 3 months, but that's only available in Europe, actually. There is now an FDA-approved testosterone unguenate for men to take orally. It doesn't work, though. I mean, you can't get the levels that you need. And again, it's horribly expensive. As far as testosterone patches, there are none available in this country for women.
We'll do this last question and then we'll be. So can you hear me?
Mm-hmm.
Sorry. I do a lot of weight management, and I think everybody knows that perimenopause is a very difficult time for women with weight gain. And I'm just wondering what the menopausal literature shows about weight loss. Women often want to know, if I start hormone therapy, am I going to lose weight? And so wondering what your literature shows.
Sure. Thanks. That's a great question. So in general, menopausal women gain weight on average of at least 10 pounds, the menopause muffin top, if you will. So data would show that oral estrogen replacement lowers visceral fat, actually. So in general, all of these hormones need to be balanced out, and specifically testosterone increases lean muscle mass and also lowers visceral adiposity. So in perimenopause in particular, there's a deficiency of progesterone because of anovulatory cycles, and then low testosterone, as I pointed out earlier. Estradiol, again, WHI study among others, showed a lower risk of diabetes in women who are taking oral estrogen. And if you look, there's, I believe, 2 studies looking at the combination of testosterone replacement with semaglutide, showing that there's less lean muscle loss with testosterone concurrently used with semaglutide. If you look at overall, then in men, there's not a lot of data in women, but if you were to look at the aging male study, that was done before we were even really testing men's levels for testosterone. We just treated based on symptoms at that point in time. But that was a 5-year study. I believe 497 participants, all but 4 lost weight with testosterone replacement. More importantly, they lowered abdominal circumference, and about a third of those men resolved their diabetes over that time frame. So essentially, testosterone replacement in men cured their diabetes. And if you look at basically type 2 diabetes in men, pretty much every male has low testosterone. And if you replaced or fixed their testosterone, you would improve their metabolic parameters, but that takes at least a year or more to see the metabolic improvement.
Thank you both very much.